Welcome to episode 27 of the Psoriasis Geek podcast. I'm your host, Gemma Bogue, and today we're talking to Dr. Laura Coates. Laura is a consultant rheumatologist and an academic researcher at the University of Oxford in the UK. Today we talk about her special area of interest, which is psoriatic arthritis. Now, even if you do not have a psoriatic arthritis diagnosis, we're focusing on early stage in today's conversation. So we start off by talking about the fact that a number of people with psoriasis do not realise that they have symptoms of psoriatic arthritis. We talk about what those symptoms are, and some of them are really unexpected. So it is possible that you have symptoms that you've attributed to something else that may actually be psoriatic arthritis. So even if you don't think this applies, just stick with the first 5 minutes because it will be worthwhile. If you do have a diagnosis of psoriatic arthritis, then the rest of the conversation will interest you because what we talk about are things like how you can make really informed decisions about care. Do you want to take methotrexate? If you want to take a biologic, how you get there. And we also talk about the kind of data that you need if you decide that you want to take a more natural approach to healing. Laura is really good at being open about exactly the kind of things that you need to look for. And she's really focused on data. So she tells you what kind of tests you need to be looking at to make an informed choice. We also cover some of the risks of making uninformed choices. And then at the end of the interview, Laura gives the best bit of advice I've heard. If you have had an experience with your GP where you've gone in and you've talked about the fact that you're concerned about aching joints, but your blood tests have come back negative, she explains the importance of this. So stick around to the end because you won't regret it. Now, let's move over to the conversation with Laura. But before we do, the notes that go along with this interview are at www.thepsoriasisgeek.com/early-PSA. And we talk about a couple of medical studies in here, and I will link to those in the blog post. So welcome to the Psoriasis Geek podcast, Laura.
Thank you.
You've come highly recommended. I asked around for who I should talk to about psoriatic arthritis and your name came up a lot. So congratulations.
Thank you.
Now, psoriatic arthritis is surprisingly common in people with psoriasis, isn't it?
Yeah, so I think it obviously depends how hard you look for arthritis as to how much you find. And it also depends a bit on how severe the psoriasis is. So we know that people with more severe psoriasis are at a slightly higher risk of getting arthritis. So it's probably between 15 to 30% of people with psoriasis who will develop some form of psoriatic arthritis, but that varies a lot. So some of it can be quite severe and quite disabling. Some of it can be quite mild, and often those patients either don't have a diagnosis or maybe don't get referred through to us.
Now, the symptoms for psoriatic arthritis, are they quite similar to rheumatic arthritis? Like, what's the difference between rheumatic arthritis and psoriatic arthritis?
So it's probably our biggest decision is whether this is psoriatic arthritis or not. I would say for the most part, if somebody has psoriasis, the chances are that they will have psoriatic arthritis and not rheumatoid arthritis. I have a very small number of patients who have both rheumatoid and psoriasis, and we're convinced they're separate things, but the genetics behind them are quite different, so often they don't overlap. So if you have psoriasis, the chances are if you have inflammatory arthritis, it is psoriatic. But obviously a lot of people get joint pain and it's not psoriatic arthritis. So I see quite a lot of referrals who turn out to have wear and tear arthritis, like osteoarthritis, or mechanical joint pain from lifting children, from typing with 2 fingers, one of my chaps this morning. And we also see a slightly higher proportion of patients who develop gout with psoriasis as well. So that's an important differential, particularly for older men. We see more commonly gout.
So I know you've done some research where you were testing out different types of questionnaires with patients with psoriasis. Was it in a waiting room, or did you randomly select patients?
Yeah, so we've done a few different studies like this with the screening questionnaires. There are, I think, more than 5 now screening questionnaires for psoriatic arthritis, and they're all broadly similar. The idea is that the patient fills in a questionnaire which asks them about some symptoms or signs of psoriatic arthritis. They're all a little bit different. And then if you reach a certain score, then it suggests that you might have psoriatic arthritis and you should at least be referred. And we've tested a number of these, some in clinics in secondary care, some in hospitals with patients with psoriasis, and some in primary care in GP land, where we went out. We actually invited patients by post and then went and ran study clinics in the GP surgery in the evening so that they could be assessed.
And in those surveys, you found that there were a number of psoriasis patients who had symptoms for psoriatic arthritis, and they weren't aware of that. Is that right?
Yeah, so we find a fair proportion of people who have some symptoms and haven't been diagnosed. Obviously, in general, they tend to have slightly milder disease. If they have really disabling disease, they often do get referred, sensibly by their GP. But so it's usually milder patients, or sometimes patients with bad spinal disease.
Right. And is that because the milder symptoms of psoriatic arthritis are easy to pass off as something else? Or is it because people like me are very good at making up excuses and just pretending it's not happening?
Yeah, I think it's all of those things. So I think patients ignore it. They put it down to other things. Often it's triggered off by something physical anyway, and then maybe doesn't settle. So you can blame it on the fact that you slept funny or injured something. And so you minimize it and ignore it. We also see that from GPs as well. So if you don't have very obvious joint swelling and very obvious problems, then often the GPs will minimize it because they're used to common things being common. So actually more commonly it is osteoarthritis or a sprained ankle or a normal joint pain that isn't psoriatic arthritis. So I think there are lots of reasons why people don't get referred. And we know from some audit data in the UK that the psoriatic patients take much longer to present to their GP compared to the rheumatoid patients. They take longer to get referred from their GP to the rheumatologist, and then they take longer to get diagnosed once they get to rheumatology. So everything just tends to run a bit slower.
And is that because the symptoms of psoriatic arthritis are a bit more transient? Because I've heard people talk about the pain and discomfort moving to different joints. Is that the reason why it's slower to diagnose?
Yeah, so I think people are much more variable. So rheumatoid presents with a much more typical pattern. And also it typically comes on quite quickly. So patients suddenly notice a big change and usually quite a lot of swelling in the hands as well. And so they push for a referral and they see their GP. Often with psoriatic arthritis, it can be a lot more variable. So it can be just 1 or 2 joints. It can move around. It can be outside the joint. So it can be tendons that are affected. And often they're painful, but then the GP can't find a swollen joint and he's not quite sure what it is. So that it's not picked up that well. And therefore not referred that quickly. And it can be a much more milder disease. It can come and go and not bother people too much, in which case they just get used to living with it.
The severity of the disease, is that in the same sort of, can that be linked to lifestyle? If people who have milder disease, do they tend to, I know because obesity with psoriasis can worsen psoriasis and smoking can worsen psoriasis. Can the lifestyle factors lead into worsening of psoriatic arthritis as well?
Yes, so we know smoking is worse. So smoking is bad for your joints as well as for your psoriasis. The data around obesity is a little bit more tricky, so it certainly is a factor. Part of it relates to how well you respond to the drug. Part of it relates to how we measure it. So measuring psoriasis, you can look or you can take a photo and it's a relatively objective assessment. Whereas when we're measuring arthritis, we're often measuring more subjective things like pain and function and movement. And those things are obviously affected by obesity as well. So some of it is directly making the arthritis worse. Some of it is affecting general ability to join in with life and participation. So that may be part of it.
Right. It's quite complex, isn't it, psoriatic arthritis? There's lots of different things that sort of play into there, isn't there?
Yeah.
Now, if I went to my GP and said, I think I have psoriatic arthritis, and he referred me to a rheumatologist, what happens then?
So we see our new patients in the early arthritis clinic. So we have a specific clinic for any new inflammatory arthritis. So that can be rheumatoid or psoriatic or anything else. And the patients see me for an assessment first. So we take history, ask about what's been happening, and examine their joints. We very often use ultrasound as well to help with the diagnosis. So X-rays are useful to a point, but often not that helpful in early disease. Whereas the ultrasound can look beyond the bones. It can look inside the joints, inside the tendons, and see if there's inflammation there. And it can be useful to tell between different types of arthritis as well. So we're lucky that we have an ultrasonographer in clinic. So we get the ultrasound on the same day, and then we see the patient straight after the ultrasound. And if we're concerned that it's active psoriatic arthritis, then we'll offer treatment that day.
Can you identify psoriatic arthritis that is not active using the ultrasound?
Yeah, so we can see thickening in the joint or thickening in the tendon, but without any active blood flow. So usually if it's properly inflamed, we can see the kind of red colour light up on the ultrasound. And then we know that there is increased blood flow to that joint. If, for example, somebody's had arthritis and we've partially treated it, then often we can see the thickening still there, but the inflammation goes.
Right. I've had aching in my joints before, and I know when I was a child, I had swollen joints when I went into hospital. But then for a year, it didn't happen again. So I just thought, well, there's no point in going to the doctors because they won't be able to see anything. But actually, it still probably would be worth it if you can pick that kind of stuff up on an ultrasound.
I think it helps if it's relatively close to when it happened. If it's a year later, then it's probably gone back to normal.
Okay, but so guys, don't be like me and put it off. If your joints are aching, just go to your doctor straight away.
Certainly, if it's coming and going, a lot of patients come and they say it's always a good day when I come to rheumatology. Actually, my joints aren't too bad today, and I wish you'd seen them last week or yesterday when things were bad. And I think that doesn't worry us too much. So if you've had inflammation relatively recently, we can probably pick something up. So that bit of variability day to day, I wouldn't worry so much about.
Fantastic. So is methotrexate the first drug that you give? Because I've had quite a few people ask me about other options, and a couple of people who've decided not to take the methotrexate. Now, I know that in some cases of psoriatic arthritis, the joint can actually become damaged. So I wondered if we could talk a little bit around early stage treatment options and what the risks are if you decide not to go down that route.
Yeah, so establishing prognosis in psoriatic arthritis is probably the hardest thing for us to do, at least for individuals. And obviously that's what matters if you're the patient. So we know overall that patients have less X-ray damage than patients with rheumatoid arthritis, but they actually have similar impact on quality of life. And that's either because they're getting symptoms in other joints that we're not picking up, because usually we only X-ray hands and feet, because they've got symptoms from tendons and other things that don't show up on X-ray. And obviously they're also living with psoriasis. So they've got the impact of the psoriasis on their quality of life. So overall, kind of similar impact on quality of life, but people vary massively. So we have patients with mutilans type arthritis, which is pretty rare, but where patients get really significant damage to the bones, often developing shortening of their fingers and toes because the bones are damaged so much. And obviously that can have a massive impact on your function long term. But then we have a lot of patients who have either none or very mild damage to the bones. And if they continue like that, it's a lot less of a concern. So overall, the stuff that we know that can be useful is that the more joints you have that are inflamed, the worse your prognosis, so the more you potentially need treatment. If you have high inflammation markers on your blood test, which 50% of psoriatic arthritis patients never have, even when they have active disease. But if you do have that high CRP, then that increases your risk of damage. If you have marked functional disability at the beginning, so if you're really struggling to do day-to-day things like opening car doors, cutting your meat, the normal things that we ask about in clinic, that's a poor prognostic factor. And if you have damage at baseline, so if you've had the disease for quite a short period of time and you have x-rays at your first visit and you already have evidence of damage, that's probably the biggest predictor of you going on to get more damage. So we have to kind of use that limited information to try and translate that for an individual and say, how much do you need to take treatment, or how much can we relax about this? And it's that balance of treating symptoms now, so making you feel better and be able to go to work and do your normal life, and improving your joint pain and potentially your psoriasis as well. And also your long-term outcomes. So if you can manage with it now, do you store up any problems in the future?
Right. So what should a person in the initial consultation be thinking about? What kind of questions do you think they should be asking?
So I think you want to know where the inflammation in your joints is. So is it in the joints themselves? Is it in the tendons? We haven't talked about it much, but between 1/4 and 1/2 of patients have involvement in their spine. That can be tricky to spot. People often ignore it because back pain is normal. And it may need an MRI as well. You can't see a swollen back joint, so you need to scan to look for that. So where the involvement is, and then what treatment people recommend. And I mean, I have patients who have very open discussions with me about, do I really have to take this? And if I don't take it, what are the risks? And I can't tell them exactly, but I can give them a rough idea. And I often explain to patients that there are some patients that I will push to take therapy, not make anybody. I can't make anybody take anything. But I will say, look, I really think this is important, and I think you are high risk, and I'm worried that your joints are going to be damaged, and I really think you should be on treatment. And there are other patients where I'll say, look, you've got relatively mild disease. We don't know much about patients with very mild disease. They're not very well studied, but we think your chance of developing damage is pretty low. Your symptoms are pretty mild. If you're managing day to day with the odd painkiller, doing regular exercise, sometimes diet people find helpful, then I'm happy to watch and wait.
I imagine your advice on diet is the same as the advice for diet on psoriasis. There's no specific trigger foods. I mean, obviously, low sugar, just a healthy diet is what you're recommending, basically.
Data-wise, it's just healthy diet and maintaining healthy body weight, or getting to a healthy body weight if you're not there yet. And we know that weight loss is very important in patients who are obese, in terms of response to therapy and controlling disease. Beyond that, lots of patients tell me specific things, but nothing is consistent. So lots of people find one particular food upsets them. If it does, then stop eating it, unless you really like it.
Yeah, that's me and red wine, 100%. Now, you've done a lot of work on sort of a different approach to early care, haven't you, for people who've been not newly diagnosed? And I think, correct me if I'm wrong, it's called Treat to Target.
Yeah.
Can you explain that a little bit? Because I know you're involved in trialing the effectiveness of this in a clinic in Oxford.
Yeah. So the idea of Treat to Target came from other conditions, and the most kind of commonly recognised ones are diabetes and hypertension, high blood pressure, where it's been shown that if you control your blood sugar in diabetes, or your blood pressure, if you have high blood pressure, to a particular level, then that reduces the chance of you getting problems later on. And so we essentially saw that concept in rheumatology, and it to some extent, it makes a big difference really in the grey cases. So patients that come to see me, there are some patients who limp in from the waiting room and I know that they need more treatment, whether I assess them properly or not. It's obvious. And I have other patients who skip in completely fine. And I know that it's going to be a quick and easy consultation. But it's those things in the middle. And I think patients typically underplay things, particularly if their disease has been really bad and they've responded quite a lot, but they still probably have some disease that's still around. They kind of remember how bad things were and they think, actually, I'm pretty good. And so they don't make much of a fuss about what they have that's left. And as doctors, we're also good at ignoring that because it makes our life easier. So it's those great cases where things are all right, but maybe not perfect, where this really makes a difference. So the idea is that instead of just saying, how are you doing today? To which all patients everywhere say fine, even if they're not.
We
measure something. So we measure the number of tender joints, the number of swollen joints, your level of skin psoriasis. Usually we just do a body surface area, so rough number of palms of psoriasis, the number of swollen tendons that you have, tendon insertion points. And then from the patient point of view, we measure pain, a patient global assessment, so in all the ways your psoriasis and arthritis affect you, and a questionnaire called the HAC, which is a questionnaire about function. So it's about how well you can wash yourself, feed yourself, do daily activities, walk up a flight of stairs, that kind of thing. And we're aiming for a particular level on each of those things. So to control disease across all those different domains, some doctor, some patient measured, and we're aiming for that particular target. And we trialled this a number of years ago now. So the study opened in 2008 when I was doing my PhD. And we recruited just over 200 patients who had newly diagnosed psoriatic arthritis. And we split them randomly into two groups. So one group got normal NHS care. They got seen every 3 months. They got their normal treatment, their normal assessments. And the other half got this treat to target approach. So we saw them every 4 weeks. So it was a big commitment from the patients. And we did that assessment every 4 weeks. And if they weren't hitting the target, we increased their therapy. And it did mean that we used a bit more stronger medication. We used slightly higher doses. And if they didn't respond to the first medication, then we moved on quicker to second and third medications. But we did significantly improve their arthritis, their psoriasis, and their function and quality of life compared to the normal care. So we've shown that it works. And you could do that tomorrow. It doesn't need a new drug. It's using the drugs we've already got in the clinics we've already got, and trying to make that a kind of real life approach. So that's what we're now doing in Oxford. We're doing the similar approach, but this time just seeing people every 3 months, because every 4 weeks is not practical in the NHS. It's also not practical in patients' lives because people have other things to be doing. And it's a bit early to assess the response to most of our drugs. So actually, if you see people every 3 months, you get an idea about whether whatever you did has worked and whether you need to change something again.
Right. So because you saw the patients more frequently, did you start them off on maybe a lower dosage of drug than you would have given if you weren't going to see them for a long period of time because you knew you could increase it, or you didn't, you gave them all the same
reasonable doses?
Right.
So I'm a great believer in reasonable doses of methotrexate because I think people give up too soon or think that it hasn't worked. And
okay.
You need a reasonable dose to test it. And it's probably a higher dose than you need for rheumatoid arthritis, and it's probably a higher dose than you need for psoriasis as well. It doesn't mean it suits everybody. Obviously, some patients didn't suit methotrexate and they switched to something else, but it means you've given it a good test. So we started at kind of a moderate dose of 15 milligrams, but we escalated pretty quickly as long as people tolerated it to give you the best chance of responding within that kind of 12-week window before we change something else.
Right. So I assume that now both groups, theoretically, you're seeing them every 3 months. But the fact that you are testing so many different things gives you a much more comprehensive indicator of where each person is, so they can have more personalised care. Is that what you're finding?
Yeah, so the aim is to try and make it fit the individual. For the most part, we follow a similar protocol, at least to start with, but we can be flexible on what the first drug is. If methotrexate isn't appropriate, that is our most commonly first line drug. Then whether we switch or combine with different medications and what our second drug is very much depends on the patient and on the risks and other diseases that they might have, like blood pressure or liver problems. So we kind of pick specific to them. Biologics, obviously we do get to, and we use particularly for patients with spinal disease a lot earlier as well. To be honest, because of the drop in cost with adalimumab that happened back in November, that tends to be our first line for everybody because it's so much cheaper. And at least for the arthritis component, there's no evidence yet of one drug being better than another. All of them get pretty similar outcomes. And that's obviously different to skin psoriasis, where certain drugs have been shown to be obviously better than others. We don't have that in the biologics and psoriatic arthritis. So we nearly always use the TNF inhibitor adalimumab as first line, but then we can switch to other drugs or use other drugs first line if there's a reason they can't.
Does it work in a similar way to psoriasis where you have to try methotrexate first before you move on to the biologics? Yeah.
Yeah, so our rules in the UK are that you have to have at least 3 tender and 3 swollen joints, and you have to have failed 2 standard drugs. So that's usually methotrexate and one other one. The only exception to that is the spinal arthritis. So if you have significant arthritis in your spine, it doesn't respond to methotrexate or any of the other tablets that we have. So you jump straight to biologics. So for that, you have to have a spinal pain scores of over 4 out of 10. And you have to have failed 2 standard anti-inflammatories, so drugs like ibuprofen, naproxen, that kind of thing.
Okay. So my last question is, for those of us who do not live in Oxford, what's the best way to maximise the effectiveness of our consultations with a rheumatologist? So we've got tell the truth, try to remember back to life before psoriatic arthritis and use that as your baseline instead of baselining against your last flare. What else could somebody do to get the most out of their rheumatologist?
I think plan for it, write down questions, because everybody always forgets them and then they think of them afterwards. So if you've got things you want to ask, then write them down. If you've got particular issues that you want somebody to address, then ask about them. And be open. You know, if you're worried about taking a drug, I'd much rather you tell me than say you'll take it and go home and not take it. If you're worried about something, tell me and I can talk you through it. And if we decide not to take it, that's fine. Or we can try something else. So I think plan it, work out what you want to get out of it, where you want to be, what your target is, and what your queries or questions or concerns are, and be as open as you can in the appointment. So that we can try them and help you.
Perfect. Is there anything that you think people should know that I haven't asked you yet?
I don't think so, no. I think the thing about normal blood tests is important. So if you've got patients going to see GPs, they very much think of rheumatoid arthritis when they think about inflammatory arthritis because it is more common. And so typically they test for a CRP, for inflammation levels, and they test for rheumatoid factor. And for most of our PSA patients, those blood tests will be normal.
Right.
And I've had a number of patients, not all of them, but I've had a number of patients who've then been told, oh, it's okay, you don't have arthritis. The blood tests tell us that. And that's not the case. To really get to the bottom of it, you need to see a rheumatologist and potentially may need an ultrasound as well.
So is that a case of just demanding to see a rheumatologist when you're at your GP surgery?
I think it's pointing out that if you have psoriasis, the risk is that you have psoriatic arthritis, and that there is no blood test for psoriatic arthritis that works. If there was, we'd be recommending it, but there aren't any. So if there's a query about arthritis on a background of psoriasis or a family history of psoriasis, then it probably is worth a referral.
Okay, amazing. That is invaluable. Thank you so much for talking to us today, Laura.
No problem.